Before we get started too, also I have no conflicts of interest to disclose, so just making you aware. So this presentation, I am going to discuss the connection that nutrition has with the five M's, looking at what matters, mobility, medications, mentation, multi-complexity. We'll be looking at how nutrition has a little bit of a role in all age-friendly care. So we're going to describe the role that malnutrition has on health outcomes. That's the primary purpose of this presentation. We'll identify barriers to optimum nutrition in our aging adults and discuss strategies and resources to improve dietary intake in this population. So just talking a little bit about how we can apply this, just reiterating kind of what the five M's are. I know there's four M's, five M's. I do like the fifth one, the multi-complexity one that has been added because it really reiterates the importance of our interprofessionalism and how much of an impact all of us have on each other's disciplines even. One area where nutrition is really relevant though is what matters. This is where we talk about the patient's goals, the values, the preferences they have. But one reason that this is most relevant is because it's something that all of us connect with. Every person needs to have some source of nutrition, preferably by mouth, but we can feed them by a tube or parental nutrition, and we have nutrition support options also. But it's something everybody identifies. It's something that brings us pleasure, we celebrate, it sustains life. It's applicable to all across the entire life cycle. Um, it's also an area where family wants to be involved too. So um, we look at all the different factors. One thing that I consider also is like as we're aging too, our intake is going to be affected and it's going to change. So we need to look at this as we go on as well. And then looking at mobility, this is something that is going to change, of course, as we're aging, but nutrition plays a significant role in this. We know that protein has an impact on lean muscle mass. Also, energy intake, if we're not able to sustain enough energy to be mobile or to get around, our energy intake is going to diminish as we are able to eat less. So it kind of it can be a double-edged sword if they're not able to get adequate intake in order to help them sustain their energy. Medication is also important. You're really going to see this with Olivia's case study too. As we age, the number of medications are typically going to increase. A lot of these medications have a lot of nutrient interactions that we need to be aware of too. We prescribe medications, but we don't necessarily consider the direct impact it has on nutrient absorption or interference with being able to utilize those nutrients specifically. There's significant information or significant research out there too, just supporting the impact that nutrition has on mentation. Also, I, I come sometimes clump like mobility and mentation together just because a lot of the research looks at that together. But we know that proper nutrition or adequate nutrition is really going to impact both our ability to function cognitively and physically. And then multi-complexity working together with your interprofessional team, because as you'll see again in Olivia's case study, there's really the importance that we all have in working together and helping it become more sustainable care for the patient. So I just wanted to do a quick poll with you guys too. Whether you're working independently or whether you're working with a facility, if you just want to put in the chat, do you or your facility screen for food inaccessibility? And do you or your facility screen for malnutrition? And you could just put yes and yes or no and yes or okay. So I'm seeing a little bit of a combination of both. Very happy with those of you guys who are screening for both. That makes me happy. Okay. Okay, so we're all pretty familiar with the impact that nutrition has on our health. We know that it significantly impacts overweight, obesity, heart disease, diabetes, certain types of cancers are the risk is going to increase with certain type of dietary intake. We're very familiar with that. Malnutrition is a less understood area though. We have medical nutrition recommendations for all of these, including malnutrition. For malnutrition specifically, we're going to be concerned about that energy and protein need. And then based on what our assessment is of that patient, we're also going to be looking at what our macro and micronutrient needs will do. So if you consult a nutrition professional to do a nutrition assessment when you suspect malnutrition, they're going to be assessing previous intake, medical history, and different factors that could play a role in why their needs would be increased. I also want to address malnutrition versus undernutrition. This is something that very commonly the words get used interchangeably, but they don't necessarily have the same definition. Malnutrition also includes excess or imbalances. Very frequently, it gets overlooked that overweight and obesity people are also at risk for malnutrition. One thing that we don't necessarily consider is energy dense is not equal to nutrient dense. An example would be going to a fast food establishment and ordering a burger and fries and a soda. You're getting significant calories, but you're not getting very good nutrition from that. So we don't necessarily want to use those interchangeably. And that's a stigma that hasn't necessarily come to fruition or understanding at this point yet. But that's something to bear in mind when you're working with this population. Just because they're overweight does not mean that they have nutrition stores even. Where under nutrition, we're going to be looking at that's related to insufficient vitamins, minerals, and energy intake. And that's when we're going to look at underweight and nutrient deficiencies as well. So we do have the dietary guidelines for older adults. I'm not going to get into the new dietary recommendations or changes like that. We do have consistent evidence-based recommendations that have been well established for many years, and most of those recommendations are going to be fruits and vegetables, whole grains, protein, ensuring that there's adequate fluid intake. That's really going to be needs to be reiterated in our aging adults. Limiting our added sugar, saturated fats, sodium intake, and then alcoholic beverages. It is important, though, even though we have these dietary recommendations, that not one size fits all for every person. We have to do an individual assessment whenever there's that need. So when we're doing assessments or doing our screenings, excuse me, we're going to look at if there's risk where they need to have a nutrition assessment. We also have to look at therapeutic diets too. There's different risk factors associated with our different therapeutic diets, and where we're at with quality of life and whatnot versus safety. So with therapeutic diets, we may be modifying textures, we may be modifying consistencies, perhaps there's swallowing issues, chewing issues. Or else they may need to follow different dietary recommendations based on certain diagnoses like cardiovascular disease, renal therapy or renal diagnosis for specifically is a very restrictive diet. So we need to be mindful of whatever recommendations that they have that are related to their care. So one thing that's important to recognize with aging adults is even though their intake is decreasing and their energy needs are decreasing, their nutrient intake or their nutrient their nutrient needs increase, excuse me. Um, so that's something to be mindful. We definitely need to be considerate of their calcium intake, vitamin D, potassium, dietary vitamin, and then B12 especially, and especially looking at their protein intake. So there's multifactorial reasons that their increase or their intake is going to decrease. Excuse me, I'm stuttering. And there's different factors that we would look at with that. That's why it's important to do a full assessment. Um, a lot of it is early satiety. There's less interest in consuming food. Even living situation, if they have a partner who they're eating with, we very commonly see a decrease in intake when we're working with somebody who's recently lost a spouse or partner. We also there's differences in tasting. We see senses diminish too. So there's less interest in consuming the foods that were once more enjoyable to them. So those are all things that we have to consider when we're working with this population. So one thing I wanted to share too is there's a link between the susceptibility of the aging process and also the malnutrition too. So we know with aging that there's going to be changes biologically that increase the risk for chronic diseases. Our physical and cognitive well-being is going to change, which can also directly affect the intake. And then socioeconomic changes. So if a person recently retires, it generally tends to hit a little bit harder if there is a big expense that comes up for somebody who's doesn't have that consistent income. And then also food safety is a big concern with this population too. With that diminishing of senses, sometimes the ability to see foods that where they might be visibly unsafe to somebody with healthy eyes, they may not be able to see that sense of smell, and they may not be able to taste if it actually tastes sour or ripe. So those are all things that we need to consider. But we see that connection with malnutrition also. There's a physical decline. There's loss of muscle mass and muscle strength. We see impaired immune function, management with chronic diseases and impaired wound healing. All of that's going to increase with malnutrition. Unfortunately, with malnutrition too, especially in our aging adults, there's an increased risk of mortality and morbidity. So malnutrition for older adults, if we look at those risk factors, they're going to be increasing with the risk of the chronic diseases. So we see that connection with the increased risk of an older adult developing a chronic disease. That risk also increases more with malnutrition. We also see an increased risk just in general for malnutrition. And then malnutrition has a greater impact on older adults. So as we age too, the impact of malnutrition is going to hit an older adult more than it would hit a younger adult, even with the same diagnoses of malnutrition. So what we see with malnutrition, this is the criteria that we use. We use the American Society of Parental and Enteral Nutrition, who collaborated with the Academy of Nutrition and Dietetics to look at for diagnosing malnutrition, excuse me. So we look at energy intake, we look at any weight loss changes, subcutaneous fat loss, muscle loss. We do assess for edema and also reduced grip hand strength because there's a lot of evidence that shows that there's increased risk of malnutrition and even mortality with reduced hand grip strength as well. What we're specifically going to be looking at for the case of this scenario, though, is malnutrition in the context of social and environmental circumstances. So that person doesn't have adequate intake to, or doesn't have adequate nutrition or intake to meet what they need. So we're going to see significant changes in their health related to that. So if we look at the impacts that on health that malnutrition has, or even in food accessibility, it impacts their ability to recover from the diseases. So a lot of the times, if we see somebody inpatient who has malnutrition, the trauma is going to be much more significantly impacted. Wounds are very challenging to heal. Infection is going to increase. There are certain physicians that won't even want to do certain procedures if the risk of malnutrition is too high because the outcomes are very poor. We also look at its impact on immunity. It's just they don't recover as well, and increased risk of mortality and morbidity. With that, we also see there's increased risks for falls, especially in our aging adults. We know that uh, a fall or a hip fracture can have a significant impact and even is an increased risk of mortality as well. There's several factors that can malnutrition or food insecurity can weigh in on muscle wasting, loss of strength, and decreased bone mineral mass. All of those are going to increase with poor intake and if a fall occurs. This is actually one of my more recent favorite articles that I've come across from the New England Journal of Medicine. And it really shows about how multifactorial malnutrition is. So you see everything from age increasing. Uh, there's all the different factors related to different medical impairments that are going to increase it. And then also just the lack of ability. We see dysphagia, we see tremor, nausea, and vomiting. Some of our medications are related to that. Malabsorption is very common. Just that chronic inflammation that happens with aging as well. And we see that one of the main things that are the reason that is typically happening is low intake and high requirements. So it becomes a double-edged sword. Once again, just there's many things that are going to be contributing to it. And that's what also makes malnutrition and addressing that more difficult. When we're working with this population, though, we want to come up with an intervention and we want to help them overcome their barriers. We need to look at what is accessible to them. One thing we really need to be concerned about when we're working with rural populations is what they do have access to. So, as rural healthcare professionals, we know that we sometimes have patients that are coming from several hours away. That is sometimes the case with their ability to access food too. So, they may be driving several hours in order to access a Walmart or whatnot. There are typically sometimes, I'm just going to say sometimes there are convenience stores and whatnot too, but you also have to look at what foods are available to in those convenience stores too. Those places are not typically going to be sourcing fruits and vegetables and whatnot. They're going to be looking at they have more convenient foods. That's their convenience stores. Um, we're also going to look at the ability to prepare food. So, is this person able to stand up and prepare their food, especially when we work with older adults that are having diminished physical abilities? Are they able to stand in order to prepare a meal? Do they have the equipment to prepare a meal? We a lot of the times as nutrition professionals too, we're also preparing simple recipes that can be completed with a low number of ingredients and minimal work too. And then we also need to look at what do they have as far as it's not actually uncommon to find out that somebody doesn't have a working stove or refrigerator. So those are things that we all need to know when we do our interventions is what they have access to. So some of the things that we will look at with food insecurity, specifically with older adults, is some of the statistics related to that is there are more than 12 million seniors and older adults that experience food insecurity in the United States. Do we have anyone here from the Bismarck area? There's one little district there that is actually considered, no, Fargo, that actually has one of the recognized lowest number of food insecurity in North Dakota, which is pretty cool to get national recognition for the lowest food insecurity in North Dakota. Unfortunately, that's not everywhere across the state, um, but we do have North Dakota, South Dakota, our regions, we need to be especially considerate because our seniors are at greater risk of developing food insecurity. And that's even going to increase more when we are working with those who may not have access to food nearby. Another thing to look at is seniors with disability are 2 to 3 times more likely to be food insecure. Medications are going to affect that as well if they are required to take certain medications as well. Those who rent versus own their own home are more likely to be food insecure. So we do know that there are programs like SNAP out there to support other programs, but not everyone is going to have access to that. Um, Another factor that is actually going to increase the risk of food insecurity with older adults is if they reside in a home with their grandchildren. So we do know that there's benefit to community eating and working and eating with multiple people. So there's benefits to living in the home with the family and eating together. However, when you add that food insecurity component, it's assumed that that's because the family is more likely concerned about feeding the children versus the grandparents. And if you think about how your grandparents wanted to make sure that you were fed too, it makes sense. But more than likely that the elder is going to be affected than the child when that food is insecure, that home is food insecure. Counties with the highest food insecurity are disproportionately rural. That's another thing that we really need to be considerate as practitioners in a rural community is most of our patients are going to be from rural areas too. I liked this map just because it kind of showed the differences between the metropolis versus the rural areas because it just emphasizes how much more we need to be concerned about the rural areas too. We do have a few areas, but even those metro areas, we have to worry about food security for different reasons. Things that we need to consider though is the establishment of the food store as well and what types of food are available. So even when they do have access to them, not every place is going to have what is considered more nutrient dense. Do they even have transportation to that facility? I actually did my internship for my dietetics program in an urban area. But transportation, how we saw was a barrier there is people were taking the bus and having to be on the bus for hours. So are they making sure that they're keeping their food at safe temperatures and whatnot? Those are all things that we need to consider. And then what is affordable to them too. We consider this even when we do our recommendations too, is we want to set them up with goals that are realistic to them. So we'll look at whether freezer options or freezer foods, vegetables specifically, or fruits are attainable to them or storage ability too. Supplemental programs, even though we have these programs in the country, that doesn't necessarily mean that the people have access to them. There's about 1 in 5 people who are food insecure that do not necessarily qualify for resources too. And if you think about it, the numbers for what for the poverty line in the United States, if that person has the income that is just slightly above that and they're paying rent, then most of their money is going to go towards or through towards rent. And then if you add any medications on that, oftentimes medications will be prioritized over food too. So if the person is not able to take their medications and take their eat adequately, then we're going to have even more significant problems. So moving from there and just seeing how how this information can actually affect a patient. Olivia, like I said, had a wonderful example of how food accessibility and nutrition played a role in how the patient outcome. So I'm going to let her go ahead.
Okay, can you hear me?
Yes.
Okay, so hi everyone. My name is Olivia, and like Danielle said, I am a student at the University of North Dakota. And my case study is addressing malnutrition through the nutrition care process. And so before I get into the case study, I just wanted to kind of note that my case study is structured using the ADIME process, which is assessment, diagnosis, intervention, monitoring, and evaluation. This is an evidence-based framework that is used in clinical nutrition practice, and the format supports the problem identification, any targeted intervention planning, and outcome-focused evaluations. I don't have access. There we go. So my patient is Ro. He is a 64-year-old male who was admitted on November 3rd with sepsis secondary to pneumonia. He was admitted to the emergency room. He presented with failure to thrive, a COPD exacerbation, progressive weakness, shortness of breath, and a persistent cough. He was then transferred to the medical surgical floor where he was treated for his sepsis, and then he was soon discharged on November 7th of 2025. So a little social history about Ro. He has been unemployed since COVID-19. And so I would just like to note here that any economic instability related to that COVID-19 pandemic, including any job loss or reduced income, likely contributes to insecurity by limiting consistent purchases and adequate nutritious foods. So any prolonged periods of inadequate food intake may be associated with barriers that Roe has been contributing, which have helped or that have hindered his nutrition status. He is Caucasian with no identified religious status. He has not a very good family support situation where he lives. He's not married. However, he does have a girlfriend that kind of helps him out whenever she is available. However, it's important to note that around this time of the case, she had recently got a procedure done that has kind of hindered her, and she hasn't been able to help him out for some while. He has been going through some food insecurity since his unemployment in COVID-19. Since then, he has been living off of Social Security money since he does not have a consistent income. He used to receive Meals on Wheels services about 5 days a week. However, that had recently discontinued prior to being admitted, just because he wasn't able to renew his subscription. And then, with the help from his girlfriend, since she was the main source of his transportation, he was able to go to the food pantry and the Salvation Army and use those resources in the community. However, since the girlfriend was unable to transport him around the community, he was unable to use those resources. And then he doesn't have a functional vehicle due to it being broken down, and then his financial situation wasn't able to help him get that fixed. We can move into the medical and family history of Roe. So he is diagnosed with COPD, hepatitis C, a mental health diagnosis, and cataracts. Procedures included cataract removal and diagnostic colonoscopy. However, these procedures are nutritionally insignificant. Family history includes cerebral aneurysm, lung emphysema, and diabetes. The food and nutrition related history for Roe. So prior to admission, he reported that he had not eaten for 2 consecutive days. Therefore, it was not appropriate for me to get a nutrition recall from prior to being admitted. Roe does have a good appetite, despite his ability to meet his nutritional needs. That's limited by that chronic food insecurity and then worsening symptoms. However, he is able to prepare meals independently. So, like Danielle was talking about, he does have a working stove, working oven, microwave, and a fridge available in his apartment. However, he is experiencing shortness of breath and general weakness that may contribute to his way of getting adequate food. But we can also look into his COPD that may affect his breathing and his mental health conditions that may reduce any energy levels. So together, these contribute to the shortness of breath and any general weakness. Roe does not entertain in any physical activity. However, he does have a cat in his apartment that he does take care of. Roe doesn't have any food allergies or food intolerances. And from this short history that I've gathered, we can already tell that Roe's nutritional status possibly is severely compromised. Moving along to some anthropometric measurements. So upon admission, Roe weighed 100.3 pounds. He's 5 feet 9 inches. This leads his BMI to being 14.8 kilograms per meter squared. So since Roe falls well below the normal range, he is very, very underweight. It indicates severe malnutrition risk. So this will trigger us to do a full in-depth evaluation of his nutritional status and identify any underlying causes that may contribute to this very low BMI. Roe stated that his usual body weight is around 119 pounds, but there's an undetermined time frame of when and how long this 19-pound weight loss occurred. And then I used the Homley equation to gather his ideal body weight, which is 160 pounds. So energy and protein needs. Before I go into the caloric and protein needs, I just wanted to mention that I used his actual body weight of 100.3 pounds. It is a more accurate predictor of his metabolic expenditure in those underweight individuals. And so starting with caloric needs, I used the Mifflin-St. Jeor equation, which gave 1,236 kcals. With the addition of a 1.2 stress factor and 1.2 activity factor, it increased the needs to 1,780 kcals. I then used a weight-based method of 35 to 40 kcals per kilogram, which gave 1,592 to 1,808 kcals. Here too, I just like to note that 35 to 40 kcals per kilogram is on the high end of a weight-based method multiplier, but the reason why I used it was due to how nutritionally compromised Roe health status is, and then two, a typical range for the weight-based method in a healthy individual is around 25 to 30 kcals per kilogram. So even here we can see how nutritionally compromised Roe's health status is. I then compared the two, Mifflin-St. Jeor and then the weight-based method, and then I recommended 1,600 to 1,800 kcals per kilogram. Then for protein, I used 1.2 to 1.5 grams per kilogram as a multiplier, which gave 55 to 68 grams of protein. Here we see just a snippet of Roe's biochemical data. These are just some laboratory values that are either out of range or pertinent to assess his overall nutrition status. So here we can see Roe's calcium, hemoglobin, and red blood cell counts are low, and his BUN is high. But other predictors that could help address a full nutrition status is his BC, his phosphorus, and his CRP levels. Some nutrition-focused physical findings. So through clinical observations, I identified severe muscle wasting and fat loss of the temple region, orbital fat pads, his clavicle bone region, deltoid muscles, and triceps. Roe presented with adequate dentition, and there was no chewing or swallowing difficulties. Our last section of the assessment portion of the process is medications. And so Roe was prescribed with multiple different medications. However, I just picked out the few that are significant and may cause a potential drug-nutrient interaction. And so I've highlighted the side effects of the interactions. However, it is important to note that some of these medications include ones that are associated with a decrease in appetite, which may contribute to reduced oral intake and negatively impact his nutritional status. And so this is what Danielle was kind of touching on how some of these medications may impact the nutritional absorption, cause just a decrease in appetite, which can significantly contribute to the nutrition status of an individual. So now we kind of move on to the nutrition diagnosis of that process. And so I've gathered my assessment data. And here I've identified two different diagnoses that are appropriate for the case. The first primary diagnosis is severe malnutrition or the undernutrition related to the pathological or physiological causes that result in increased energy requirements as evidenced by the severe muscle wasting and fat loss of the temple region, orbital fat pads, clavicle bone region, deltoid muscle, and triceps, as well as reports of bimouth intake meeting less than 75% of estimated energy requirements for less than or equal to 1 month. And I use the American Society of Parenteral and Enteral Nutrition. I use that guide to help kind of influence my nutrition diagnosis and ensure that I have a proper diagnosis for the patient. My secondary diagnosis is inadequate energy intake relating to lack of access to food or artificial nutrition, as evidenced by intake not meeting estimated energy requirements. So I've got my assessment, I've got my diagnosis, and now we can move on into an intervention for Roe. And so looking at nutrition interventions, we look at an effective inpatient management of malnutrition requires that coordinated multidisciplinary approach to ensure safe and adequate nutrition to support and improve our clinical outcomes. And so, looking at initial inpatient interventions, we should focus on addressing any underlying contributors first. So, that may look like any infections, dehydration, or any electrolyte imbalances the patient may be experiencing. Once we're able to medically stabilize our patient, then the first line of nutrition intervention is to increase energy and protein intake with any food fortification, the nutrient-dense food options, and oral nutrition supplements. And so these interventions are essential for promoting weight gain and restoring any nutritional status. So once I've kind of dove deep into what an intervention may look like, I have identified the prescription goal and plan for Roe. So his nutrition prescription is patient to consume 450 to 500 kcals at each meal 3 times a day, as well as 300 kcals from the oral nutrition supplements. The goal for Roe is patient to consume 75 to 100% of all meals and oral nutrition supplements to meet 1,600 to 1,800 kcals and 55 to 68 grams of protein per day within 3 days of the prescription initiation. How am I going to do this? Through oral nutrition supplements, communication with that multidisciplinary team, the nurses, social workers, case coordinators, and even the hospitalists, as well as any nutrition education that may benefit Roe. So here we can implement our intervention. So due to Roe's adequate dentition and no issues with chewing and swallowing, he is on a general diet with room service. He is encouraged to order double portions as tolerated. He is receiving 1 CIB shake and 2 Ensure Plus protein drinks per day. That 8 ounces of a CIB shake is providing 10 grams of protein, and then 16 ounces of the Ensure Plus protein drinks are providing 32 grams of protein. We will like to monitor the tolerance to oral intake that looks like any abdominal pain, diarrhea, constipation, or bloating that Roe may be experiencing with those added oral nutrition supplements, as well as weight trends. So we want to make sure that Roe does not lose any weight, but maintaining that weight to help restore any muscle mass and fat loss. We will like to look at any nutrition, any pertinent labs that are to help identify nutrition status. And then due to his severity of malnutrition, Roe will be reassessed every 3 to 5 days. So looking to prepare for beyond the hospital, Roe wasn't at the hospital for very long, and so we have to look like what his malnutrition and his adequate food intake may look like outside of the hospital. So I use motivational interviewing techniques to create self-efficacy within the patient to make the changes and get the help they need outside of the hospital. And so ensuring that Roe is confident in the resources that his community provides and any nutrition education that he may want. And so the nutrition education that's beneficial to provide to him is any high calorie, high protein food choices that are affordable and even commonly available at in community resources such as the food pantry, Salvation Food Pantry, or any food banks that are available to him. Coordination of care is super critical, and referrals to that case manager or social worker are very, very, very critical, and to address any ongoing barriers such as his food insecurity, those transportation services that he may need, and then especially his loss of the Meals on Wheels services that needs to be renewed. Then looking at what the case manager or the social worker can help Roe with, they were able to allow or educate Roe on the assistant programs that are in the community, the transportation services, as well as the home and community-based services to help him with his quality of life at home. So then our last section of the ADIME process is monitoring and evaluate. So we want to monitor the intervention that was in place and see what his outcomes kind of look like kind of prior to discharge and what they may look like outside of the hospital. And so ensuring that Roe is meeting that 75 to 100% of all meals and oral nutrition supplements to meet the goal of 1,600 to 1,800 kcals and the protein needs per day. We did assess the pertinent lab values. However, it would be beneficial to obtain that CRP value to monitor any stress values that Roe may be experiencing. Weight trends ensuring that Roe was not losing any weight, but recognizing that since it was such a short period in the hospital, that significant weight gain may not have occurred. But the upward movement and any restoration is very important, and it is an indicator of improvement. And then I did ask Roe just some questions in regards to any high calorie, high protein food choices that may be affordable for him and see how confident he was to choose those when he gets that access and um, the access to those community resources. And then lastly, looking at follow-up and discharge plans. So making sure that, like we've mentioned, Ro has all of the resources and needs that he wants outside of the hospital. And so Ro has many barriers that inhibit him from adhering to his proper nutrition needs. So the case manager worked with us in the discharge process, making sure that he's aware of all those resources in the community. So transportation services, the city's area transit, and the city bus are available to him. The home and communities-based services to support him at home and make sure that he is following up with those prescriptions at his home, as well as the case managers were able to send him home with a food pantry basket from the facility to kind of hold him over until his Meals on Wheels services were renewed. And then just looking at nutrition education, making sure he's confident and he knows that what is available in the community. So, kind of wrapping up, this case demonstrates how chronic food insecurity can really drive prolonged inadequate intake and lead to severe malnutrition. And so, for Roe, the chronic food insecurity led to prolonged inadequate intake, resulting in severe weight loss, functional decline, and even increased vulnerability to illness. And so, addressing these malnutrition requires more than just a short-term nutritional support that we're able to do in the hospital, but looking at what it looks like outside of the hospital, what we can do, and what we can do in that multidisciplinary team to support him as he goes home. And so recognizing any social determinants of health, particularly that reliability and access to food. And then without addressing any food insecurity, the risk of ongoing malnutrition increases, as well as repeated hospitalization remains fairly high. And so that was kind of my case study that I was able to see and work through in my practicum experience.
Thank you, Olivia. And just to kind of wrap this up, I wanted to talk about what we could do as practitioners. So in this case specifically, we saw how relevant it was to Rose's situation. Likely he came in because of malnutrition and his condition was severe. There was a lot of factors that contributed to his food insecurity, to even being able to go to it, his loss of meal on wheels. But what's important is that we are asking these questions to find out what is the cause of the nutrition, food insecurity. So doing those nutrition screenings. It's great that a lot of you guys are already asking and doing those food insecurity. You can do it just in three simple questions. Malnutrition, the same. There's there's two different validated tools that are most commonly used that you can easily ask to determine the increased risk of that person's risk for malnutrition specifically. This case specifically really reiterates the importance of having that interprofessional team. So if you see that there is any sort of nutritional needs, just making sure that you're referring them to a dietitian or nutrition professional who can do that full assessment for them. And then also same for a nutrition professional, making sure that I'm able to make that referral too. So knowing your team and knowing what resources are available to them. So he was having complications with access to resources. So as a nutrition professional, I'm going to have to adapt what resources I have available to me to help him as well. Following up with that patient too is also going to be critical too, because he could very easily fall off the chart and even become more ill, or with a BMI of 14, death is going to increase, or the risk of death is going to increase significantly too. But it's also very important to advocate for these patients as well, and to help them achieve what their goals are and help them gain access to that.